Hello, everyone, and welcome to today's live broadcast and keynote presentation, The Dynamics of the Unconscious Brain Under General Anesthesia, presented by Dr. Emery N. Brown, Warren M. Zapol, Professor of Anesthesia, Harvard Medical School, Professor of Computational Neuroscience, M.I.T, Director, Neuroscience Statistics Research Laboratory, Anesthetist, Massachusetts General. I am Alexis Corrales of Labroots, and I will be your moderator for today's event. We are delighted to bring you this educational web seminar presented by Labroots. Labroots is the leading scientific social networking website and producer of educational virtual events and webinars. Before we begin, I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. Just click on the Ask a Question box located on the far left of your screen and type your question into the drop-down box that appears on your screen. Dr. Brown will be responding to your questions via email. If you have trouble seeing or hearing the presentation, please click on the Help Desk button located in the promotional board at the bottom center of your screen, or use the Ask a Question box to let us know that you're having a problem. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education's Credits tab located on the top right corner of the presentation window and follow the process to obtain your credits. Today's webcast will be available for on-demand viewing through June of 2018. Please join me in welcoming Dr. Emery N. Brown. I will now turn the presentation over to him.
So today what I'm going to talk about is what happens to the brain under anesthesia. And I've entitled this talk, Decipher the Dynamics of the Unconscious Brain Under General Anesthesia. I'm Emery Brown. I'm a professor of anesthesia at Mass General Hospital, Harvard Medical School, and also Professor of Computational Neuroscience and Medical Engineering here at M.I.T. And so today what I'm going to do is take you through a little bit of the work that we've done to try to understand what happens to the brain under anesthesia. So here's the outline I'm going to follow. We're going to first just take a quick clinical look at what happens under general anesthesia. Then I'm going to speak specifically about loss of consciousness induced by the drugs propofol, and I'll go over a couple of other anesthetics as well. Then I'll say something about what happens to the response to anesthesia as we get older, the aging brain. And then finally, I want to leave you with some ideas for the future, which I'll call reanimation from general anesthesia. You'll see what that means when we get to that. So let me just tell you the punchlines right here before we start. So general anesthesia, regardless of how you think about it now, the brain is not turned off. It's actually dynamic. And one of the main things is the brain, the states are created by the circuits in the brain generating oscillations. The drugs drive them into these oscillations. And we think that this is one of the primary ways through which the drugs produce these altered states of arousal, by inducing and sustaining these oscillations. These oscillations are so large they're readily visible on electroencephalogram. They change systematically with age of the patient and also dose of the drug. Therefore, it provides a very straightforward way of monitoring the brains of patients receiving general anesthesia. And finally, what I want to leave you with, as I mentioned earlier, is a way to turn the brain back on. Right now, what we do is we let the anesthetic drugs wear off, but perhaps one of the ways that we can reduce brain dysfunction following anesthesia and surgery and speeding recovery is by turning the brain back on, right? So, and the final thought that I want to leave you with is that we're studying anesthesia for the sake of improving patient care for those who need surgery. But as I hope you'll get a sense of, this is also a way of studying the brain, and I would argue that it's a paradigm which to date has been underutilized. So what is general anesthesia? So it's a drug-induced reversible state consisting of unconsciousness, amnesia, you're not supposed to remember, analgesia, it's not supposed to hurt, akinesia, it's helpful if you're not moving around while the surgeons are operating. So if you take these first four conditions and you take out the word reversible in the first sentence, then they'd be synonymous with death. And on that list of things which is not cool, that's certainly very high up there. So we create a reversible state, and if you look down here at the bottom, you see it says you have stability and control of the physiological systems. So we put you in this state, we maintain control of your heart rate, blood pressure, temperature, your stress responses, and then we bring you out. Now I've put the sentence there, it says it's not clear how anesthetics work. And what I want to give you a sense of is, just with a few kind of empirical looks from the beginning, that that's not the case. And hopefully by the end of this, you'll appreciate that a lot is actually known how general anesthesia is produced. So, but before I do that, let me just tell you practically what we do when we take care of patients in the operating room. And this is what we call balanced general anesthesia. So we use different classes of drugs to create the states of anesthesia. So if you look here where we start with amnesia, we can give you drugs which will make it difficult for you to form memories, benzodiazepines like Valium-like drugs, or the hypnotics, which would be a drug like propofol, or the inhaled drugs. The inhaled drugs which we currently still use are ethers. We've changed their chemical structure a bit, but they're still just modern-day ethers. For pain, we primarily use opioids, although the inhaled drugs would work as well. And to create the state of unconsciousness, we use barbiturates, propofol. Propofol is probably the most used anesthetic, and again, the inhaled drugs. And then for immobility, in order to make it so that you are not moving while the surgeons are operating, we'll actually give you a drug which relaxes your muscles. They're primarily anticholinergics. They block the cholinergic transmission at where the nerves intersect the muscles. But the inhaled drugs do that as well. So you can basically see that the inhaled drugs is in each one of the categories. And so this is where the idea of balanced anesthesia comes about. I could use one drug and achieve all of these, but at the cost of having tremendous side effects. So the benefit of using multiple different drugs to create the same state is we get mostly all of the good effects of those drugs, let's say the opioids and the creating analgesia, and fewer of the side effects by just using a single drug, right? And then we also administer drugs to maintain stability and the integrity of the hemodynamic system. So in order to make this a bit more concrete, I'm going to play a little video for you here, which is the video of the electroencephalogram, the EEG, the brain waves of a woman whom I took care of it's been about 4.5 years ago now. So she's 60 years old, she's coming to have thyroid surgery. And in all of our operating rooms at Mass General Hospital, we have EEG, so we can measure the brain waves of patients who are receiving anesthesia. And as I'm going to show you, we can use this to track the states of the patients while they're receiving, while they're under anesthesia. And so there are 4 leads here. There are 2 up at two on the left, 2 on the right, and they're marked. They're L1, R1, L2, R2. And this is just going to be a standard induction. This isn't edited at all for time or anything. I'm going to give her a bolus dose of propofol, about 150 milligrams, and I'm going to explain to you what happens to her as this transpires. So I'm going to start the video now. And I'll just take you through the various parts of it. So if you've never seen EEG before, those are eye blinks. You can see they're across all the leads. They're very large artifacts that occur when patients move their eyes. And what you're going to see in just a second here is a lot of noise appearing, right? And the reason this noise appears is that if you inject propofol into a vein, like a small vein on the back of my hand here, it burns when it goes in. And so this is what's happening to her. So she's tensing up. So she's tensing up her muscles. So that's why you're seeing this large artifact. And it's going to get noisier, right? So just watch it here. It's quite noisy. But this is actually going to be good for pedagogical purposes because you're going to be able to see precisely when the drugs take effect and she starts to become sedated and eventually lose consciousness. So I'm going to stop here in just about another 5 or 6 seconds here. So right here. Now, you see those oscillations there? So you know how they become flat, the noise has disappeared. And if you look at each of the vertical lines, each vertical line is a second. So between each vertical line, you see the oscillations go up and down about 12 to 16 times a second. This is what we call a beta oscillation. And if I were planning to anesthetize her so that she would have to give her anesthesia for, let's say, a colonoscopy or just a procedure that needed sedation, this is how I would dial the propofol until I saw these oscillations. I would just hold the dose there. But she's passing right through this. I'm just going to play this a little bit further. Now watch what happens next. You're going to see look at this, large slow oscillations, right? That's her brainstem becoming inactivated, just like in slow wave sleep. The brainstem is most inactivated. That's the deepest stage of sleep. And now you're going to see her transition into another stage where it's flat and now burst. Flat, and then burst. So this is a very profound state of coma. So she's profoundly unconscious, beginning first when you saw those slow oscillations appear. So let me just go through what I've shown you here. So this is her awake at A. You see she has very small amplitude oscillations. And then she went to this sedative state where we saw the beta oscillations. And then we went down to here, to this state E, where you saw these slow oscillations. We refer to slow oscillations as oscillations which have a frequency of less than 1 cycle per second. Then you saw burst suppression. And then if you look at the periods between the bursts, she's actually isoelectric. Her EEG is actually flat. So these latter states, beginning from here, I'll add one more, D, going from D down to G, these are profound states of coma, and these are states in which a patient is sufficiently unconscious in order to have surgery. And what we try to achieve for this particular drug, propofol, is to achieve the state D, because there you're sufficiently unconscious to have surgery, but you're sufficiently unconscious but not too unconscious. So we try to dose the drugs to that particular target. I want to make, there's a final state here which is paradoxical excitation, which I won't say much about. But I want to make a general comment about the oscillations and the size of them, because it's really important to understand, and it's well illustrated here. When you're awake, the EEG, let's say an average young adult, is around 5 microvolts. And as you go into deeper stages of anesthesia, you can see the oscillations get to be larger. For example, like in states D and E there, they're about 20 to maybe 50 microvolts, the amplitudes are. And in order for this to occur, you have to get large numbers of neurons doing almost exactly the same thing, kind of in unison. So you can get this sense of how much this is a situation where the drugs are taking over the circuits in the brain and basically driving them. Or let me say this another way. The EEG under anesthesia is the strongest signal-to-noise ratio for any application of the EEG, and that includes sleep, whether it's to study meditation, whether it's to diagnose coma, whether it's to perform cognitive studies. And we have the strongest signal coming out of the brain, the EEG signal coming out of the brain, but ironically, we make less use of it than any other subspecialty. And that's something which we're trying to change now in practice across the country. Right? So I'm going to display these EEGs as spectrograms here. And this is an illustration of this. So on the y-axis, what you have here is, on the x-axis, what you have here is time. On the y-axis, you have frequency. And then the color code is basically coming out at you. The darker the color, the more red the color, the higher the amplitude. And if you look above here, you see at the beginning, so this is the spectrogram over time, about 40 minutes of a young woman I took care of who was having a small procedure, and we needed to just sedate her for this procedure, so I gave her a bolus of propofol at the beginning, and then I maintained her on an infusion of propofol for about 20-25 minutes or so. And you can see that she went from the state of, see the slow oscillations there at the beginning, about 6 or 8 seconds, and then she broke into at about 8 or 9 seconds, she broke into a pattern that shows the slow oscillations along with the slow and alpha oscillations. So the alpha oscillations are roughly between 8 to 12 cycles per second, and we're going to talk a lot about them. So this is what you see here now, this picture here that has a very strong red stripe at 10 cycles per second and a strong red stripe going from about 0.1 to 4 cycles per second. This is the standard signature for propofol. And then when we turn the drugs off, somewhere around about 27, 28 minutes, you can see the oscillations fade, and she woke up over there about 32 minutes. So this is a standard signature of propofol. The induction in the beginning, the slow oscillations, the maintenance with the slow and alpha oscillations, and then the recovery at around 32 minutes or so. So these are the people that I've had the good fortune to do this work with. Patrick Purdon, my colleague at Mass General Hospital, Nancy Coppell, a very well-known, distinguished mathematician at Boston University, Shenung Cheng, who is now at Washington University in Seattle, Ahmad Eskandar, our collaborator at Mass General Hospital, neurosurgeon, Eric Pierce, anesthesiologist at Mass General Hospital, Laura Lewis, who is one of our Ph.D. students, who's now on the faculty at Harvard Medical School in the Martinez Imaging Center, and Sid Cash, who's in the neurology department at Mass General Hospital. All right. So before I go into a few more particulars, I want to show you another bit of phenomenology. Then we'll talk mechanisms. So we've done a number of studies in humans as well as in non-human primates as well as in rodents to characterize the state of anesthesia. And this is a display based on one of the human studies we did, and we record whole head EEG in volunteers who let us give them anesthesia through increasing doses and then decreasing doses over a period of about 2 hours or so. And we took advantage of something which has been known for years, two factoids. So it's been known for about 40 years now, that there's an oscillation that starts in the back of the head and moves forward when someone becomes anesthetized. So if you take that 10 hertz oscillation and that I showed you in the previous slide, in the two previous slides ago, it actually starts in the back of the head if someone has his or her eyes closed, and then it moves forward and concentrates in the front. And then it moves backwards. And this phenomenon is called anteriorization. It was discovered by John Mitchenfelder and John Tinker back in the late 70s. They were both at Mayo Clinic at the time. They showed this in studies in non-human primates. So what we do is, so that's the first factoid. Then there's a second factoid, which is, if you just stand here now and you close your eyes like this, and I put electrodes in the back of your head, I can measure a 10 hertz alpha oscillation. Pretty much everybody has it, perhaps 5 to 10% of people don't. We tend to lose it as we get older. But it's very, very robust. It's a very robust finding. So what we do is we ask our study subjects to close their eyes, and then what I'm showing you here are 44 sites on the head. So up at the top there, that's the sensor sitting up here around the forehead. The far left is the sensors by the left ear. The far right is the EEG electrodes or sensors by the right ear. And the two in the back are the two which are here at the occiput, at the back of the head. And this is a male subject, so he has his eyes closed. So you can see the two red stripes in the back there. If you count up 0, 10, 20, he has a 10 hertz oscillation, which you can see at these two sites in the back of his head. Now, if you look up at the upper left corner here, you see it says baseline. So this is him just lying there. So he's showing you this 10 hertz oscillation, which pretty much everybody has, right? So now what we're going to do is we're going to start giving him increasing dose of propofol. The doses are going to increase about every 14 minutes. And you're going to watch this oscillation move from the back of the head to the front. It'll concentrate in the front and be highly concentrated in the front at the highest dose. Then we turn the drug off, it's going to move backwards. So I'll play the video here for you. So, started. So now the drug, you see level 1, the infusion has started. And now you see how it's breaking up in the back. And you see now it appears very, very robustly in the front there. And here what I'll do is I'll just stop it right here. And this isn't even the highest level yet. This is level 4. You can see the 10 hertz oscillation is now in the front. It's disappeared entirely in the back there. All you see is slow oscillations in the back. And this goes from about the center of the head out to the front of the head, this 10 hertz oscillation. And if I continue to play this forward, so now 5 is the deepest level, and each level is 14 minutes. So you can see it's at the deepest level. Now we turn the drug off, and now the oscillation moves to the back. All right? And it's returned. Right? And the patient wakes up, or the study subject wakes up. So I showed you what happens. I explained the alpha oscillation, but when we looked at the spectrogram of the young woman under anesthesia, we saw slow oscillations also. So let me tell you what's happening with the slow oscillation. Their dynamics are quite different from those of the alpha oscillation. And this is, I think, one of the best illustrations of what's happening with the slow oscillation. These are electrophysiological recordings made from humans. So these are patients who've come for epilepsy surgery, and they get electrodes implanted in their brains near where the neurosurgeon and neurologist think that the epileptic foci are. So they're implanted in one surgery, They stay in the hospital for a period of 5 to 7 days off medications. Once they've seized enough so that they get a sense of where the seizure foci are, they then bring the patients back to the operating room. They remove the electrodes, and in a second visit to the operating room, they then perform the resection. So these are recordings from neurons in the human brain and also neural field potentials from neurons recorded from circuits in the human brain. And if you look on the left here, what you see is what it looks like when someone's conscious, right? And you can see, if you look down in the bottom row there, you see the neural activity. You can see that the neural activity pretty much occurs wherever you want, and the oscillations are of smallish amplitude. Now, after the person lost consciousness, you see a dramatic change. So there are 3 features here I just want to draw your attention to. First of all, look at the large, slow oscillations. They're across all 3 electrodes, the red, blue, and the green, and they correspond to the locations there on the side of the brain, just off of the temporal lobe there. And if you look at where the neurons are now spiking, if you see on the left, they could spike pretty much wherever they wanted to. Now on the right, they're only spiking at the minimum. In this case, these are the neurons which are near the location of the red electrode. They're only spiking near the minimum of that oscillation. And so the oscillations, or excuse me, the spiking activity is now gated. It can only occur at certain times. So imagine that this is occurring the same way across the locales of all the slow oscillations. And see, the slow oscillations, unlike the alpha oscillations, which are in sync with each other across the various parts of the brain, the slow oscillations are entirely out of sync. So this represents like fragmentation of the cortex. In other words, for the red neurons in the red location to communicate with the ones in the blue location, they have a very narrow phase window where they can do it. However, if they want to communicate with the neurons in the green location, that's going to be very, very difficult to do because they emit spikes at different times. So we think that this is one of the mechanisms through which the anesthetics are driving the brain into a state of unconsciousness because it's impeding its ability to communicate wherever it wants to. So why is this important? Why would we care? Excuse me. Why would we care about this? Well, here's why. So what most frequently happens is that I get requests from journalists to talk about awareness under anesthesia, a case of mine perhaps where I had a patient who was aware under anesthesia and I didn't realize it. And they find that exciting because it makes anesthesia mysterious. It makes it, woo, and it makes it seem like there's something that we can't quite understand. And nothing could be further from the truth. First of all, awareness under anesthesia is not a public health menace. It occurs in 1 to 10,000 to, let's say, 1 to 20,000 cases. It's a fairly rare occurrence. However, when it does occur, it gets a lot of press, and recently there's been a lot of discussion about this in the popular press because of a book that was just released by Kate Cole-Adams, a writer from Australia, in which she discusses the whole phenomenon of anesthesia in terms of awareness. I mean, that's the focal point of the entire book, a principle of the entire book. And what we know now is that there's no reason for awareness to occur. So I've gone back to this slide here where I'm showing you the spectrogram. So if someone came to me and said, Emery, the last time I had surgery, I had awareness, I'd say it's not going to happen this time. So, and here's one way I would prevent it. I would dial them down. I'd administer propofol until I saw the alpha oscillations and slow oscillations. And if anything that I've said up until now is correct, that the alpha oscillations represent the thalamus and cortex tied up, the slow oscillations represent this very broad cortical fragmentation, it's going to be extremely difficult for someone to be conscious during those states. So that's a solved problem in 2018. The reason it might not be practically a solved problem is that most anesthesiologists don't use the EEG the way I'm describing it here to take care of patients when they're administering anesthesia. So the risk for the awareness remains, but the way to prevent it is very, very clear. So I just wanted to put this in here to say that I've shown you that the oscillations, let's say like the slow oscillations, are associated with the production, are associated with the state of unconsciousness. But you might ask, if I were to produce slow oscillations, would I see, let's say, an animal becoming unconscious? And this is an experiment which we did a few years ago. It's part of the work done by Laura Lewis in her Ph.D. thesis, in which she put optogenetic probes into an A there. You can see they're placed into the reticular nucleus of the thalamus, which is this large inhibitory network around the thalamus. And what she's doing is with optogenetics, stimulating these inhibitory neurons there and getting them to shut down essentially the outflow of information going to specific parts of the thalamus. And if you look over here in B, you see that when the laser's turned on at 0, see there's no power there, and all of a sudden when the laser's turned on, you get this large slow oscillation. And then if you look down in D, you can see exactly the same thing. And when the laser comes on, you go from this sort of high frequency oscillation to the large slow oscillation. And the part which isn't apparent from these diagrams here is that with this, you see a decrease in arousal in the animal, suggesting that not only are the slow oscillations at least associated with a decreased level of arousal, but inducing them could probably be a mechanism for decreasing arousal. And again, I just draw the analogy here to slow wave sleep. The deepest stage of sleep, when the brainstem is most inactivated, is during slow wave sleep. So these slow waves are likely a causal mechanism through which the anesthetics are inducing inducing unconsciousness. Right? So this is what I just told you. Why does propofol make you unconscious? The alpha oscillations and the slow wave oscillations. The alpha oscillations tying up the thalamus and cortex. The slow oscillations fragmenting the cortex. I showed you this anteriorization, this movement of the oscillations, the alpha oscillations from the back to the front. And this may be one of the mechanisms contributing to this notion of frontal parietal disconnection, a thesis as to how anesthetics are acting on neural circuits. And I've given you a sense of what happens in the brainstem by talking about the slow oscillations in particular. So I need to make this point here because it's important to understand. And it's that general anesthesia is not sleep. And if you look down here on the left, these are the various stages of anesthesia which I've shown you before. And if you look over on the right, these are the various stages of sleep. And remember, sleep is basically a phenomenon. It's a natural physiologic phenomenon where you go roughly every 90 minutes between a non-REM state, which has 3 phases, and then a REM state. So you go non-REM, REM, non-REM, REM. You do that every 90 minutes for about 4 to 6 times a night, and you typically awake from the REM state. Whereas if you look at anesthesia, you see here on the left, we give you a drug and we hold you in this state. So you have these very fixed oscillatory dynamics, which I've just shown you. And they stay there for the entire time that the drug is running, and they dissipate when we turn the infusion off. So you can basically see why general anesthesia is not sleep. Now, when we talk to patients, we typically say, Mr. Jones, I'm going to have you go off to sleep for your surgery. One of the reasons we do that is I can't go to him and say, excuse me, Mr. Jones, I'm going to put you in a drug-induced reversible coma because that wouldn't endear me to my patient. However, what I can do, and what I do actually do when I'm talking to my patient is say, I'm going to put you in a state of general anesthesia. What that means is you're going to be unconscious, you won't be able to remember, you won't feel any pain, you won't be moving. I will take very good care of to watch over your breathing, your heart rate, your blood pressure, and I'll make sure that we bring you out of this state when we finish. So what I've done is, as opposed to saying sleep, which it isn't, I just basically I give the patient the definition of anesthesia, and what you find is patients get that. They understand that. But I wanted to point this out to have you appreciate that general anesthesia is definitely not sleep. And as a further point on that, the sleeping medications, which are currently sold over the counter, or even the ones which you might get via prescription, there's no way in the world they could actually induce REM, non-REM. What they can do is, if you think of them as mild, if you think of them as sedatives, or maybe very, very weak anesthetics, that's a much better conceptual idea of what they're doing. They put you in a state of sedation, and then the idea is they're hopefully they will then allow you your natural sleep mechanisms to take over. But there's no way in the world a single drug could make you do this, go between the states of REM and non-REM sleep. And I think that's very important for us to appreciate, that what we're getting is not a state of sleep from these drugs, but a state of sedation, which is very much akin to a weak effect of an anesthetic. So there are generalizations that follow from this. I could take any one of the drugs, propofol, sevoflurane, ketamine, dexmedetomidine, and if I look at them this way, we can see that they have different dynamics. However, if I look at their spectra, we can see that their spectra are quite different. So this allows us to appreciate the differences in the drugs by looking at their spectra. And these differences in their spectral displays follow differences in the mechanism through which they work in the brain. And I wanted to point to sevoflurane in particular because it is a modern-day ether. And propofol, which we've talked about down in the lower left there, is ketamine, and on the right is dexmedetomidine. And what we can do is each anesthetic has a different signature that relates to its different mechanisms of action in the brain or in the central nervous system, and we can map out that circuitry, and we can now relate those dynamics directly to the circuits in the brain and the receptors at which the drugs are acting. So we can do a deep dive into each one of these other drugs the same way we've done a deep dive here into propofol. Right? So I want to tell you a little bit about aging now. So this is work which I've had the good fortune to do with my colleagues at Children's Hospital, Dr. Laura Cornelissen and Dr. Chuck Birdie. Dr. Siuna Keju is one of my colleagues at Mass General Hospital, Dr. Purdon, whom I mentioned earlier, and Dr. Kim was one of our postdocs who's now back in Korea. So this is propofol. So this is a 30-year-old man who's receiving a propofol infusion. Right? You can see the alpha oscillation and the slow delta oscillation. This is someone who's 57, receiving also an infusion of propofol. And you can see the alpha oscillations, the slow oscillation. Maybe the alpha oscillation is a little fainter, perhaps it's at a slightly lower frequency, a little bit below 10 hertz, but it's still there. Here's an 81-year-old woman, right? This was a woman I took care of a few years ago. She had a tumor on her chest the size of an American football. And it took the thoracic surgeons the better part of 6 hours to remove it. If you look at the oscillations you see there, you can see she has 10 hertz oscillations there. They're at a much weaker amplitude than those of the 57-year-old and certainly the 30-year-old. And if you look at all the higher frequencies, it's all blue, meaning that there's very little oscillatory activity there when she's under propofol. And this is very typical. As we get older, we see that the oscillations diminish in amplitude. The good thing about my using the EEG here was that I was able to give her a fraction of the already age-adjusted dose and know that she was well anesthetized or sufficiently unconscious in this particular case so that I didn't have to give her more. And I was able to wake her up immediately following the procedure. This is one of the advantages of using the EEG, that I'm reading the dynamics of what I see as I take care of the patient. Now here's the part that's a little bit sobering. So the two gentlemen there, the one on the left and the one in the center, are roughly the same age. The gentleman on the left's EEG looks like that of the 30-year-old, and the one in the middle looks like that of the 81-year-old. You know, we age different physically. It makes sense that our brains may age differently as well. But what's wild is that you'd be able to see it under anesthesia. So here's one way of thinking about this. If you forget about anesthesia for the purposes of putting someone in a state where they could tolerate having surgery, and think of it more as an experiment. I'm going to put in a stimulus, I'm going to measure the response. And the stimulus is the drug, and the response is going to be the oscillatory dynamics generated by the brain. Well, what's going to happen? So when you're young, you put in the drug, you put in the propofol in this particular case, and you get oscillations that look like this. As you get older, the oscillations get to be weaker or have lower amplitude. Now, why is this? Well, we don't have to invoke any concepts of like Alzheimer's or dementia. I mean, just think about it. There are 10 to the 10 neurons in the brain. They've been around pretty much as long as a person has been alive. And over time, each neuron is just getting older. So if you think about the dynamics, the myelin sheath breaks down, so the insulation, the cell volume declines, the dendrites are no longer as dynamic, they don't extend and retract as much, we produce less neurotransmitter, and the neuron is much more susceptible to oxidative stress. So you have a machine whose units are older, so that the ability to generate those dynamics just declines with time. What's wild is that you can get some sense of this basically under anesthesia. And you can just predict now what the kids would look like. So this is a 3-year-old, and here is now a 14-year-old. You can see they have exactly the same dynamics, but what's occurring is that they're evolving with time. The oscillations get to be they decline in amplitude. In fact, here's a better depiction of it. You can see that with age, the oscillations reach a peak somewhere around maybe 6 to 8 years of age, and then decline from there afterwards. And the 81-year-old would be over to the far, far right, basically like off the scale. And if you look at the very young brain, if you look at the brains of neonates, let's say 0 to 3 months of age and 4 to 6 months of age, the 0 to 3 months of age under anesthesia show essentially just slow oscillations. The alpha oscillation doesn't appear until about 4 months of age. And what's interesting is that when it appears, it's not dynamic. The dynamics that I showed you, the movement, the anteriorization, doesn't occur until the kids are somewhere around a year, perhaps 14 months of age. And this is consistent with this idea that what's probably happening is that there are not sufficient thalamo-cortical connections for the alpha oscillation to be produced. That's why we don't see it in the 0 to 3 month olds. But they're sufficiently present in the 4 to 6 month olds, so we actually see this alpha oscillation dynamics. And so this is just really a window into brain development. Again, if you think about what happens is you have these changes in excitation and inhibition that occur with time as we move through critical periods with the brain developing. It makes sense that this would be manifest with the administration of anesthetics in terms of the ability to produce or not be able to produce certain dynamics. And in particular, with the thalamo-cortical connections, as I'm showing over here on the right, they are aided, their formation is aided by what are called subplate neurons. The subplate neurons are like in the young brain, and they act as sort of ushers. They guide the connections from the thalamus going up to the cortex, and then they they pull away. So they help hook the system up. They help wire the thalamus and cortex. And what it says is that wiring is not sufficiently complete in order to produce these alpha oscillations. That would be consistent with our idea. And however, there is sufficient completing of this wiring by the time the child is about 4 to 6 months of age. So you actually see these dynamics. So again, anesthesia being a little window into brain development. So let me just leave you with this final idea of reanimation. So this is my colleague Ken Salt, and below, who's been working on this problem. And so below I have a quote from a letter to the editor that was written regarding an article that appeared about our group in the New York Times back in 2011. And the letter said, "I had my first corrective surgery due to infantile paralysis in 1949. The bill from the anesthesiologist was $400. My mother was horrified, but my father calmed her when he said it was probably $50 for the procedure, but I gladly pay the other $350 because he knew how to wake her up," right? As I often say, as anesthesiologists, you don't pay us to anesthetize you, to put you to sleep. You pay us to wake you up. And so that's what Ken has been working on very, very assiduously here for the last several years. And so this is one of the rat volunteers in his laboratory who's in this chamber where he's been anesthetized for the last 20 minutes or so with isoflurane. Again, this is one of the ethers. So he has an intravenous line in his tail vein. And what Ken is going to do is he's going to inject Ritalin, the same Ritalin which is used to treat kids who have ADHD. So now he's going to hook up a syringe and flush it in. Now watch what happens. Now we didn't turn the anesthesia off, right? We didn't turn it off. And you can see the animal's coming to, he's starting to move. He's changing something induced a change in state in him. And now he has to turn over for this to count. It doesn't count if he doesn't turn over. So there he goes. He's moving, moving. And he does make it. I've seen the end of the video. He does eventually flip. Here we go. One. Come on, dude. You can do it. One more. Come on, a heave-ho here. Old college try. Boom. He made it. Okay, great. Now, so before I tell you about the mechanisms of this, let me talk about what I call science from the word on the street. So this was an article that was in the New York Times back in 2015, and it was about the use of, or the abuse of ADH drugs, these stimulants that are used to treat ADHD. And it's the story of this, it starts off with the story of this woman who has a startup company, and she receives information from her investors that basically tell her that they need a new financial plan on their desk first thing in the morning. They're not happy with the one she sent in. So she texts her dealer. He comes up to her apartment about 11 p.m. and she gives him a wad of money, and he then gives her a bag of pills. She takes one of the pills, and she considers taking another one. And then you see there she says, several minutes later, she felt her brain snap to attention. And so this is actually what she then did was she worked from midnight to 7 a.m., slept for 2 hours, and then delivered the new financial report to the investors. So this is a common phenomenon now where people in high-stress jobs, and let me just be clear, this makes no sense. It's very dangerous. People should not do this, right? But she's using these drugs to actually stimulate her circuits and help her think better. And so if anesthesia has disrupted your circuits, perhaps a very appropriate clinical time to administer drugs like this is when to help people come out of anesthesia so you can help their circuits work better and help restore their ability to think more concretely or more clearly. So this is what I call science from the word on the street. The word on the street says that we should use this more, we should use this in taking care of patients who are having anesthesia care, right? So let me just show you this, all right? I want to show you an application of this idea, all right? So what Ken has done, he's actually studied the ability of, like, what state is the in when the rat comes back? You know, when he came back, you know, could he actually perform a task, or was he just sort of still stumbling around and maybe not functional? So he did the study, this time anesthetizing the animal, and instead of giving him intravenous Ritalin to wake him up, what he does is he stimulates his ventral tegmental area, this area which is very important for cognition and also for reward. So he stimulates the ventral tegmental area, and what we're going to show you is that when he stimulates this area, even though the anesthesia is on, the animal's going to come to, and he's going to start working. So this animal's been trained to go from left to right, and he starts on the left. Oh, excuse me, he goes to the right, and he has to execute a task. He has to touch the correct figure, and if he touches the correct figure, he can turn around and get a food reward. And he'll do this. He's been trained to do this. So when he wakes up from the anesthesia, he realizes this is what he's supposed to do. He realizes where he is. So this will happen as long as we have the stimulation on. Then when we turn the stimulation off, he actually goes back to being anesthetized. So I'll start this here, right? Right. So the stimulation is off. He's anesthetized. So now what we do is Ken turns the stimulation on. He wakes up. Now remember, we didn't turn the anesthesia off. We just stimulated his ventral tegmental area. So he looks for a reward, but there's no free lunch. So he has to go execute the task. So now he gets a reward. So the stimulation is on. Ken changes it to 20 hertz from 40 hertz. So he does it again, turns around, a little floppy, but he's executing the task. And now he turns around again. I think this time he gets it wrong. So he gets it incorrect this time, right? And the light tells him he got it incorrect. And now he's going to turn around again, right? The lights, the two symbols come on. And now Ken turns off the stimulation. Now you see the anesthesia takes over again. All right? So what's happening here? So when you're administering, or when Ken is administering Ritalin, he's increasing the release of dopamine in this very important pathway, going from the ventral tegmental area there at the top of the brainstem, going all the way up to the limbic system, up into the cortex. And this pathway is important for reward, but it's also important for cognition. So this pathway that's being activated by, in this case, the startup company executive when she's taking her Ritalin that she gets from her pusher. All right? And so the idea is that if it's helpful there, it should be helpful, as I said before, in helping people wake up from anesthesia. You could do it by administering Ritalin orally, in that case, or by stimulating this area directly. That's what Ken was just doing. So what we're showing you in this last video is that at all times there's a balance between being inhibition and excitation in the brain. When we're awake, there's more excitation. Under anesthesia, it's more inhibition. And so then what Ken is doing is he's not blocking the effect of the anesthetic directly. What he's doing is he's driving an excitatory pathway that overcomes essentially the inhibition, right? Now, when we do this in the case of someone waking up from anesthesia, we'd obviously turn the anesthetics off, and you'd also use that to enhance the excitatory effect of administering like the Ritalin. We just kept the anesthesia going here in these cases just to show you how strong the excitatory effect is. Right? So this is something that Ken has in phase 2 clinical trial, testing Ritalin as a way to wake patients up from general anesthesia. Right? So this is what I've told you. The brain under general anesthesia is dynamic. It's not turned off. We think that one of the primary ways in which the drugs work is by creating and sustaining these oscillations, and these are one of the mechanisms, as I said, these are one of the mechanisms through which these altered states of arousal are produced, in particular in consciousness. It provides a very clear, robust strategy for monitoring the brain under anesthesia because, as I said, the EEG under anesthesia is the largest signal-to-noise ratio phenomenon for anything for which the EEG is used. We've shown you how the EEG changes systematic with age and also with anesthetic. And we just showed you how you could turn the brain back on after anesthesia and suggest that this might be a way of not only speeding recovery, but reducing brain dysfunction after anesthesia. And as I said earlier, we're not only learning about anesthesia, but we're learning things about the brain. For example, the idea that you'd have different dynamics, sort of EEG dynamics as a function of age, is something which is really obvious now in retrospect, but wouldn't have predicted had we not studied the anesthetized brain across different age groups. And now we can think about very directly how that relates to brain development in the very young and brain aging in the elderly. And so this is sort of like the anesthesiologist's view of clinical neuroscience, and I'll just leave you with this idea. We sit sort of here in the middle, if you would, general anesthesia and all these other problems or topics in clinical neuroscience sort of circle around us. I'll just give you an example. So ketamine is a drug which is used to treat pain, but it's also a drug which is used to study as a model for schizophrenia, and now it's being administered in low dose as a way to treat depression. And you realize that the opioid epidemic is a problem that is rampant in the United States right now, and we use high-dose opioids in certain settings, particularly in cardiac surgery. So one way of thinking about the states that these patients are in is they've actually put themselves in a very profound state of general anesthesia where they're likely to stop breathing. So the ideas that we use to take care of patients for anesthesia could be brought to bear in helping to treat patients who have had opioid overdoses. Or if you look at epilepsy, there's a drug methylhexatol which at low dose can be used to induce an epileptic seizure, whereas in high doses it can be used to arrest an epileptic seizure. So I think that by taking a neuroscience approach to the study of general anesthesia, we do two things. We make it possible to really understand how the drugs are creating these various states and to propose and design new and better ways of generating the state, monitoring patients who are receiving anesthesia. But also we open up this whole, what I would consider this, as I was saying earlier, this untapped approach to studying the brain from a perspective which is highly informative and connects, as I'm suggesting here with this diagram, to a lot of areas in neuroscience. So I'll stop there. Thank you very much.